very excited to have not one, but two wonderful speakers joining us today. We have Dr. Perry Pickhardt and we have Dr. Ronald Summers. And for the audience, maybe I'll just give a general overview of how this dual speaker session may work. First, we'll have Dr. Perry Pickhardt presenting for the first 20 minutes or so, followed by Dr. Summers' talk for the next 20 minutes. And then after that, we'll try to have a combined Q&A. So maybe during the presentation, please feel free to post your questions in the chat or save them for the end, and I will try to moderate the best I can. So to maybe kick things off, we'll start with Dr. Perry Pickhardt's presentation. And Dr. Perry Pickhardt graduated from the University of Michigan Medical School in 1995. And
Go blue.
Huh?
Go blue.
And was a resident of diagnostic radiology at the Mallinckrodt Institute of Radiology at Washington University in St. Louis. Dr. Pickhardt served in the U.S. Navy as a department head of, and also as the head of the GI/GU imaging at the National Naval Medical Center. Dr. Pickhardt joined the abdominal imaging section at the University of Wisconsin School of Medicine and Public Health in 2003 and serves as the chief of gastrointestinal imaging and medical director of cancer imaging. And we're very fortunate to have him share some of his thoughts on AI for population health screening. And we're excited to hear his presentation. So please take it away.
All right, well, thanks a lot. Yeah, no, I appreciate the opportunity to be here. And Ron will be following on with what I hope is a complimentary, or I know is a complimentary talk to mine. And the goal is really, I'll be covering more of the clinical aspects and the specific study outcomes, and he'll give more of the technical background and detail for the AI tools that we employed for this study. So without any further ado, I'll get into it here. Here are my disclosures. And then just a little background. I've been interested in opportunistic or incidental, or there's other names you could apply. Some people object to the term opportunistic since it has somewhat a derogatory connotation to some, but basically using information that typically goes unutilized in a CT scan, which we know there's a lot of data there that that we can put to use. And rather than look at it as a negative with incidentalomas driving additional tests and costs, I like to think of the glass as half full and maybe try to harness some of this body composition data for benefits. So opportunistic in a positive sense, if you will. And we know CT scans are incredibly high frequency, high volume. There's probably 75, 80 million, maybe more body scans done a year in the US. I haven't gotten recent numbers on that. And of course, a lot of the body composition measures that we'll be looking at are things you can do manually or semi-automatically. But thanks to Ron and others, people have automated these tools. And the way we're applying them here are more as a static tool. There's no learning going on during the study I'll be talking about, but it's really applying those tools that got to the point of being robust and now applying them in more a static format. So putting that together, we're basically talking about automated opportunistic screening at abdominal CT and trying to add value to what we're doing. The different compositions we'll be looking at here. I'm going to move. Yeah, now I can see it. Fat, muscle, aortic plaque or hard plaque, calcium, liver fat, and trabecular bone mineral density are the 5 compositions that we chose to focus on, and I'll provide a little more detail on that in a moment. These are all fully automated tools that have been developed, trained, tested by Ron, of course, who made this study possible. And we've been working together for decades now, really, all the way back to our early CTC days with computer-aided detection and diagnosis. And so Ron was doing AI way before it was the hip thing, I guess. So now, specifically for this study that we're talking about, the patient cohort is over 9,200 healthy adults. These are outpatient, asymptomatic adults. They're basically undergoing colorectal cancer screening. That's why we have this unique population to look at. Their mean age is that of a screening age, 57 years. fairly even, slightly more women than men. And these scans date back to 2004 since we got our program started. So we basically took the earliest scan. If they had multiple scans, we used the earliest scan for the outcome study and had nearly a decade of follow-up from the time of CT onward on average, 8 years on average. And we constructed an algorithmic search of Epic, our EMR system, to find all major cardiovascular events. And by that, I would mean an MI, heart attack, CVA or stroke, CHF, or death. Fragility fractures are defined as major osteoporotic fractures that occur without a high impact trauma. And that would include things like a hip fracture, spine fracture, distal forearm, and proximal humerus as the definition. And of course, those that died in the follow-up was another important outcome. So you can see these, even though this was a healthy cohort, these events did occur with enough frequency to get enough patients. There were, I believe, 220 or so hip fractures in this group, which is an important subset of those fragility fractures. We also compared to the established clinical parameters, things like the Framingham risk score, which combines a lot of different factors in a multi-variable approach. I've listed some of them here. You have to punch these things in kind of all manually per patient to get these 10-year risk predictions, similar with the FRAX tool that some of you may be familiar with. This is for fracture prediction. And again, you have to enter, it's a web-based tool that you have to enter by patient, all of these. Now for the study, we're able to batch enter those, but it's not something that's been automated. But fairly complex clinical parameters and really something that's been highly validated to compare against. So just to run through some of the tools, and I'm not going to go through a lot of technical detail, but each one of these we studied, including both longitudinally and at single CT, just to try to get a sense for what levels would be best to use for the outcome study. And these were all preliminary preemptive studies to try to get to the best measure. And it uncovered a lot of things that aren't too surprising. That is, men and women have, for example, with the fat tool here, have differences in visceral fat in blue, subcutaneous fat in red here, with women having more subcutaneous fat. Sorry, I keep going for subcutaneous fat, and men having more visceral fat on average. And then over time, men tend to gain in visceral fat, shown here above the line, and women tend to gain in subcutaneous fat. Again, on average, there's differences. There's obviously exceptions to this rule. In terms of bone mineral density, this is another very robust tool that mimics what we do clinically every day, that is measure the trabecular attenuation at this L1 vertebral level. I'll show you what it looks like on the cross-sectional images. And this is a tool that, we've compared supine and prone, manual to automated, and other ways to validate this. And this is something, like I said, we've been doing for a long time with the manual approach because it's such an easy measure and it has so much value. CT is, the bone data is very robust. So we've been doing this for quite a while. And here's kind of an example. This is from a paper we wrote, I guess it's going on 7 years ago now, where we're looking at, you place the region of interest in the trabecular space. And these are just different examples of patients with normal to very osteoporotic bone mineral density. And so we found great value in doing this. And we do this every day. And here's an example of a paper where we looked at over 20,000 data points, both automated and manual, to show the age correlation. I won't go into details, but beyond the screening age for osteoporosis, gender and IV contrast are less of an issue. And you can see those with prevalent fractures, not surprisingly, tend to have lower L1 attenuation. It's the L1 level that we're focusing on. And if you use a 90 Hounsfield unit threshold for 120 kV scans, which all of our scans in this study were 120, that's a pretty good operating point for osteoporosis. And they're at a much higher risk for future fractures, which we've looked at. And these are future osteoporotic fractures in a separate cohort than what I'll be presenting in a moment. Bone density, muscle density and bulk. So we can segment out the abdominal wall musculature and look at both attenuation and either volume or cross-sectional area. Interestingly, we found that the attenuation really falls off more with age in both men and women compared to the bulk, which is cross-sectional area in this graph here. So we really are going to focus more on the density or attenuation, looking at things like myosteatosis. The calcium load, this is a really valuable tool that we've used in a semi-automated approach. The automated tool tries to mimic this by basically saying the aorta lives from L1 to L4, and this is what Ron's tool essentially uses. We looked at our large cohort in terms of the distribution. About half of patients in this healthy cohort have a 0 score of Agatston. This is the score that's used for coronary calcium scoring for those who are familiar with that. And we're basically applying that to the aorta. And then there's a huge long tail of increasing calcium load, and these patients will be at much higher risk, of course, for future cardiac events. Both men and women show increases over time, with women about a decade delayed, but they catch up, like within 10 years or so. So we first looked at this in a smaller cohort of patients where we had a semi-automated or basically a manual way of measuring, basically just using a coronary calcium tool applied to the abdominal aorta. And we were able to show that this single measure alone performed significantly better than Framingham risk score. So we knew this was going to be a valuable tool if we could automate it. Looking at aortic calcium by CT, just by splitting it up by quartile and looking over a long period of time, you can see pretty good separation between the quartiles in terms of who goes on to a cardiovascular event. Framingham risk score also does, has some good prediction, but you can see the quartiles aren't as well separated as they were with CT. So we knew this was going to be a good tool. And then finally, the liver fat tool, which quantifies, for steatosis using a volumetric approach, which surprisingly, or maybe not so much, matches really well with our manual ROI approach, where we do this clinically every day, just put an ROI in the right hepatic lobe in a fairly homogeneous area, and you get a really good correlation just to match it with this volumetric automated approach. So both can be used going forward. And of course, steatosis, like metabolic syndrome in general, is highly prevalent in our population. In fact, over half of our healthy population that we'll be talking about have at least mild steatosis based on a 5% fat fraction. Interestingly, there's not much correlation. There's only a weak correlation with BMI and steatosis, which actually bodes well for things like CT and MR, because you really can't predict somebody's liver fat based on their BMI. Almost any BMI can give almost any level of steatosis, with obviously some correlation between increasing steatosis with increasing BMI, but you can see it's just not a real strong correlation. We've published a lot of papers looking at the natural history of steatosis. We know this is something of interest, particularly for metabolic syndrome and cardiovascular risk. Also for liver-specific risk with NAFLD going on to NASH and cirrhosis, but that's not something I'll be covering here. But I would make one point that the reason, with CT, unenhanced CT in particular, we can correlate and actually provide an MR equivalent, basically an MR PDFF or a fat fraction that's equivalent both in the phantom and in humans. So we know the unenhanced CT attenuation is a very good quantification of liver fat. Okay, so that's kind of a quick overview of those tools, and basically now we combine them all together. We had to select a single measure for each of those tools, and by taking those prior works that I just kind of buzzed through, we decided the visceral to subcutaneous fat ratio at the L1 level, the mean muscle attenuation or Hounsfield units at the L3 level, Agatston score from L1 to L4, the mean volumetric liver attenuation for fat, and then the trabecular L1. These are the measures that we're going to use in this outcomes study that we'll be talking about, which is essentially split into two separate papers. We couldn't fit it all in one paper, and we were forced to split these, but they're basically the same cohort with just the different outcomes of cardiovascular risk and fracture risk. And to look at basically the total cohort, those with a cardiovascular event or death, yes or no. This is a little busy of a table, so let's just focus on death just for the sake of time. And you can see, looking at these 5 measures, that just from looking at averages, there's pretty significant differences between those that went on to die versus those that didn't over the follow-up interval. And these are all statistically significant. Liver attenuation is just a fairly minor difference, but it is significant. Most of these, though, are just obviously significant in differences. In terms of outcomes, looking at areas of under the ROC curve, we could also look at hazard ratios, and I won't have time to go into all that. But if we just look at death and just look at a few points in particular, let's look at the 5-year area under the ROC curve. So the Framingham risk score does a fairly good job in predicting death. You can see with the area under the curve here. BMI had absolutely no predictive value overall, surprisingly, basically a coin flip. But aortic calcium alone, again, beats the Framingham risk score. And this is just a single automated measure as opposed to all those cumulative, different variables that get plugged in. Even muscle attenuation also beat it by itself, which, so this is very encouraging for CT. And when you combine multiple factors, the performance gets even better. So there's a lot of predictive value in these body composition measures for both death and cardiovascular risk is similar. These are these Kaplan-Meier plots, again, just showing the quartile separation for Framingham risk. And here you have aortic calcium probably doing a little bit better in terms of separating, especially at the highest risk quartile. Muscle doing quite well. Even though the worst quartile for bone mineral density, there's some predictive value there. And then if you compare visceral to sub-Q fat versus BMI, you can see it really matters where you have your fat, not really how much is there per se, but the visceral fat driving the risk here, as you can see. And liver attenuation or steatosis also having some predictive value. Now, looking at cardiovascular events, it's a similar story, but here I'll just show you a Cox survival sort of model with a multivariate approach. If you add age and gender, you can see you improve prediction or separation a little bit, but it's really the CT factors that are driving it, not the age and sex information. So that's, again, good news for these body composition measures. And just to show you a quick example of a 52-year-old man, he had a negative virtual colonoscopy, but of course there's more to the CT than just the colon. And you can see he's got, for those who are radiologists, he's got a very fatty liver. He has a fair amount of aortic calcium, and his visceral fat is actually fairly prominent, as you can see here. And if we put that in objective terms, he was actually at the 99th percentile for visceral to sub-Q fat ratio, 97th percentile for steatosis, 97th percentile for aortic calcium. So he was very high risk in those terms, even though from a Framingham risk score, he was low risk and he was just a little bit overweight, but it's where that weight was distributed, has a lot of visceral fat. So he went on, or if we look at these numbers and model, I won't have time to go into the modeling, but you can see the model from these body composition measures would predict at 2, 5, and 10 years a much higher risk of cardiac event than the Framingham risk score would have predicted. And even risk of death was higher than the cardiovascular risk. Well, he did go on to had an MI within 3 years. 5 years after that, he had a stroke. He actually had a CT for minor trauma in 2017, which is now 12 years out. And you can see his obvious advances in aortic calcium load. His liver fat has gotten worse. This is a post-contrast study, and it even looks worse. Even his visceral fat is worse. So everything in terms of metabolic derangement is getting worse. And he actually died later that year at the age of 64. And this is something that could be predicted because of those body composition measures. Quickly turning to fractures, same story here. The FRAX score does, fairly well to predict fractures if we look at the 2-year area under the curve. L1, however, does just as well, even though it's a much simpler single measure compared to a multivariate sort of approach. And if you combine BMD, L1, and muscle, you improve things even a little bit more. And here are just those Kaplan-Meier curves to show, in fact, that there is good quartile separation. But I think it's even a little more instructive to just look at another case. This is a 59-year-old, had her CT in 2017. The FRAX score was well below the 20% treatment threshold, so not really concerning. The FRAX for hip fracture specifically is well below the 3% treatment threshold. But we see that she has a very low attenuation. Remember, anything under 90 puts them at much higher risk for future fracture. So she's at a very high risk for fracture given this 63 Hounsfield units. And I can just tell you the muscle attenuation is also quite low, and that puts her at increased risk for a hip fracture, as I'll show you in a moment. With VC, we actually can do a DEXA-like score that we add to every virtual colonoscopy just on the fly as a free measure, and that did show osteoporosis. But having said that, 3 months after this scan, she had this catastrophic hip fracture, as you can see here. She then had a DEXA, which she hadn't had before, but now that confirms the contralateral hip is indeed osteoporotic, so that didn't really help too much at this point. But interestingly, remember she had her CT in 2017. She had CTs going back all the way to 2005 for kidney stones. So she had these in the PAC system for urolithiasis. And if we just apply Ron's tool, you can see she had been dropping in bone mineral density, hitting that 90, near that 90 Hounsfield unit threshold way back in 2009. Now is clearly at risk, well before she went on to fracture. So something in the future, we should be identifying these people, I think, well before, hopefully before they get to this point, which is too late in terms of her outcome here. So also interestingly, the muscle attenuation turns out to actually be very predictive of hip fractures, actually outperformed the FRAX. Although there's no statistically significant difference, the area under the curve was greater than the FRAX score. So I probably took a little more time than I meant to, but the goal here ultimately is to have these this risk profiling kind of ready at the time of prospective interpretation. We can do this as sort of a dashboard readout with structured reporting. And I think this is something we could be applying to any CT, hopefully at some point in the future, adding value, to what we're already doing. Because there's a lot of CT. I was on CT yesterday, and our volume is continually going up. So there's a lot of fodder there for opportunistic screening. And I think we currently are not using most of this data in any useful way. So I hope going forward we can add that value. As I've shown, it really equals or even exceeds the best clinical tools that are quite complex. So I think it's definitely adding value to what we're already doing. So don't think of CT as a hammer to nail the diagnosis, but more of a toolbox that we can use to address a lot of sort of seemingly disparate things in the future. So thank you a lot for your attention.